Well, good day, everybody. I am Joe Ambrose from Roe Dental Laboratory, and I said good day because I don't know what time zone everybody's calling in from. So I just want to first say that I hope everybody is healthy and safe in this crazy time we're in right now. And hopefully today we can forget about what's going on all around us and study some dentistry. So that's me. For those of you who haven't met me, I've been a dental technician since 1968, believe it or not, and seen a lot of things happen during that time. Probably more happened in the last 15 years than I've seen in the first part of my career, but it's all exciting. And hopefully today you'll find some good tidbits about working cases up for the guided smile chrome process. I don't look at this, or we don't look at this at Roe as just making teeth. We've seen so many results and happy people with this that we look at it as we're treating the whole person. And it's a life-changing thing. Any of you who have done these know very well how important it is for people and how it does change their lives. So before we get into the meat and potatoes of this, I want to show you some results that we've had during the duration of the time we've been doing this. This is a nice case. And some of these are pretty extreme dentitions that I'm going to show you, so that it's very, you can see a very big difference in how this makes people look, and I'm sure how it makes them feel. You can see that their dentitions are just destroyed, and these people leave with probably, I would say, a better outlook on life and themselves. And they all come in with, as you know, pretty well destroyed teeth, pain quite often, infection, and this picture especially shows you what it can do for people with how they feel about themselves and how they start taking care of themselves. So I hope these three pictures excite you if you haven't been doing any of this to this point. So the presentation here is designed to provide you the best path for optimum results when you do these full arch chrome cases, and for that matter, any full arch case. What I'm showing here today is the exact protocol that we use here at the lab. When we get cases in from you, we go through a triage process of what we receive, what we need, and how we can get that all put together for you to give us the best chance for success. And basically it's dentistry. It's everything that you ever learned when you were in dental school, and we're going to apply it to what we do here. There's information that we need, required information and materials that we have to have for prosthetic workup. Master models or impressions capturing all borders and anatomy necessary for full denture construction. And you might say, why? We're doing this on a computer. We have digital impressions. If in fact that you are working on a patient and you want to make a spare denture in the event that you cannot load the case, we will need to have models representative of the anatomy that we need to make full dentures. If you don't need to make a spare denture, or you don't want to make a spare denture, then you don't need all the borders and palette that you might need for full denture construction, and your digital scans will work. We have found that with digital scanning, it's very rare that somebody can capture all the borders and anatomy needed to make full dentures. The second thing we need are confirmed bites in VDO. We ask that you document the millimeter opening desired from a measurement. We don't need to know the measurement from the nose to the chin. We need to know information like open this case 3 millimeters, open it 4 millimeters. That's what we understand. The nose to the chin measurement, we can't relate to that because we don't have a patient here. So we are going to go over what a confirmed bite is to us. I'll show you the photo series that we need, the minimum pictures that we need to confirm and verify bites that you send to us, and also aesthetics and facial features that we look at to determine VDO and things of that nature. We will need a shade and a surgery date, but we ask that you do not schedule your surgery until the online meeting that we do is finalized and approved, and then schedule your surgery. I suggest giving the patient a range of time, and once we do the meeting, then we can hone in on the final delivery date. So on your initial consultation appointment, this is obviously what we think will happen. You'll determine a treatment plan, and there are options. And we don't always have to do a hybrid case, a Chrome hybrid case. We are working on a beta project with a Chrome Natural, which is Crown and Bridge, which we can do FP1 restorations. You'll review the dental materials that you will use for your patient, and there are options there, which I'm going to go over in some detail. You need to discuss fees for the entire process, not just for surgery or prosthetics. The patient needs to know at that point how much this whole process is going to cost them. And again, give the patient a general time frame that they'll get this done in, and give them a solid surgery date when we do the planning and you finalize and approve the plan. So the production time that we need from the day that the plan is finalized in software with you is 10 days in the lab plus whatever shipping time you are in. And most of what we have out of state is a 2-day ship, but that's not all of our customers. But so just allow 10 days plus shipping, not including weekends or holidays, of course. So we have materials. We have, at this point, 4 different ways that we can make the final restorations. Obviously, the PMMA that you're going to receive for your surgical appliance is polymethyl methacrylate, the nanoceramic, and that is what everybody gets for their provisional. But the final restorations, which is something that you don't necessarily have to talk about right away to your patient, but it's good to discuss. We have Ultra Nano Trilor, ZIRCONIA, Ultra Nano Titanium, and a full acrylic wrap with a titanium frame and denture teeth. I'm going to discuss all 4 of those options now. And the first is our Ultra Nano Trilor. And as you can see, we have all the components on this picture that goes into making one of these. You see the frame, the titanium frame that is the substructure, and you see the yellow bronze cylinders attached to it. On the left side of the picture, you see the teeth, the Trilor teeth, or the Crystal Ultra that is made, with the teeth in place, and you also see the pink veneering of the gums that go around the teeth. So it's we do quite a few of these at this point. I would say, I don't know if it's 50-50 Ultra Nano and ZIRCONIA, but it's probably somewhere close. But this is a good restoration, and the benefits of it, the Ultra Nano and Trilor are it's highly durable, resistant to chipping, impervious to liquids, simple and efficient fabrication, easily relined, which is a big deal, and there's no sintering process, so nothing goes in a furnace. And some more advantages of it are that it's 60% lighter than zirconia. You've probably held some of these zirconia frames in your hand, and they're, you know, they have a weight to them. We haven't heard of any patient complaining that the weight was something they noticed, but, you know, if it's important to you to have something lighter, you know, the Ultra Nano will give you that. It's 6 times stronger than acrylic. You can adjust it and repair it chair side. And one of the most important things is that it bends and it gives under stress. That doesn't mean it breaks. It means it has a lot of tensile strength that under occlusion, where other restorations or teeth might fracture, this has a better chance of not having any fracturing problems. Nanoceramic crystal ultra, shock absorbent, soft bite, feels like real teeth. You can see on the right side of the picture the TRYIN frame, and you also see the crystal ultra milled set of teeth that we are going to actually bond onto that frame and put pink around. It's very strong, provides exceptional rigidity while still having a slight flex to absorb stress, as I already mentioned. TRYIN is the substructure that we use. It's a technopolymer framework. The two most important things about it are in red that I have highlighted. It creates a light and resilient frame for a zirconia, lithium disilicates, acrylics, or composites. So you can adapt a lot of things to a TRYIN frame. We happen to use the Crystal Ultra for it. And the characteristics of it are of natural bone, metal-free restorative solution, lightweight, durable, and resilient. Zirconia, we do quite a few of. Everybody is familiar with zirconia. It's very hard, very almost impervious to breaking. Not that they don't break, they can break. I'll give you some reasons, and in red pretty much highlights the main reason it can break. Zirconia is a very strong material that resists chipping and breakage, but it has no tensile strength. So if you screw one of these frames into place and it doesn't have a dead passive fit, there's a chance down the line that this can fracture. And we have had a minimal amount of that happen. And quite often when we go back to getting a new relationship, a new fit jig, and a lot of the time we use the existing broken frame for that, we'll put it together, and there is a difference in one fit versus another. The new fit, the new position of the implants will show that there was a little discrepancy in fit. So that's one thing, if you decide on zirconia, that is going to be one of the most important parts of the process that you go through, is to make sure everything is totally passive. And the last choice that we have, and one of our newer ones right now, we've done this before in the past, we didn't have the framework design worked out like we do now, is titanium frame with crystal Ultra Nano on top. And we have a specific design that we use to accept the crystal, monolithic crystal ultra. It's bonded to an opaque titanium frame. This provides strength with the advantage of monolithic teeth overlay, which is very aesthetic and highly resistant to breakage. In other words, if you're afraid of the zirconia because of the fracture issue and you feel better with titanium, we just don't have these frames break. So, but passivity is important, as it always is, to prevent putting one of these in place and screwing it in and have an implant under tension constantly. But all 4 of these techniques are available. We do each and every one of them on different people's cases, and we have success with them all. So the last option is the old standard, the Brandemark's original design, which is a titanium frame with acrylic wrap and denture teeth. This is probably the one that potentially has the most issues. Not that we have a lot of issues with them, but teeth can pop out, acrylic can break off. You know, we have to protect the bites and equilibrate very carefully with all of these, but especially with this one, because sometimes the materials here, if, you know, depending on the patient's situation, bruxer, grinder, that sort of thing, sometimes the materials aren't as strong as the bites that the people have. So this is something that we still make, by far not as many as we used to with all the other options that we have, but it is available. So with all of these cases, we have to have space. And my first recommendation is that if you don't have the required amount of space that's required for any of these restorations, I would say don't attempt it. And that's a pretty bold statement, but being in the laboratory side of this, we see what happens when space is violated and materials become attacked by stress and force. So with the FP1, ZIRCONIA crown and bridge with no pink porcelain, we like to have 10 millimeters of space to achieve, you know, a good result that we can say is strong enough. Now this is our chrome natural design, which at this point is in beta testing. We are doing cases with specific doctors, and we, you know, as with anything new, we have to work through issues that come up. We are doing a few more cases now. They're turning out very well, and we will announce via the internet and emailings when this is going to become something that is going to be common for us to do or available to everybody. Excuse me. The FP2s it's an FP1 that has areas on it where you're going to need pink porcelain. Bone loss in certain areas, pontic areas, things like that, that you don't want to have because the teeth might look too long or unnatural. So FP2, 10 to 12 millimeters of space for that. And the FP3, which is the chrome guided smile restorations, the minimum space we need is 13 millimeters. And I say 13 millimeters with a little caution. 99% of the time it works. But when you have people with maxillary excess or gummy smiles, that 13 millimeters can be very misleading and cause a transition line exposure. And I will go into that later in the presentation here in some detail. So pre-planning the workup appointment, and I think that this is the appointment after your consultation where the patient comes in and you get impressions and you do all your analyzation. So we're going to need models, either analog or digital. You're going to need to capture records, take a photo series, and perform facial analysis. And the performing of facial analysis is what we find to be somewhat lacking in what we receive. These are more than just immediate denture type cases. What we give patients now is something that we want to give them something very close to what they're going to wear when they get their final. So vertical dimension needs to be addressed. And if we need to open or restore, I like to say restore vertical dimension instead of opening it, because most of these cases where we need to change vertical are the result of collapse and worn dentitions, and people are not at their normal vertical dimension. So if we need to open or restore the vertical more than 3 millimeters, we suggest an orthotic that the patient can wear to confirm the vertical dimension and centric. How long they wear it is going to be your clinical decision. Some doctors will let the patient wear it for a week or however long they deem necessary. get the surgical appliance made, get the guided smile case made, and use the actual surgical prosthetic as an orthotic to be adjusted and finalized as the patient wears it. We need to capture eccentric. We need an aesthetic analysis, tooth position, incisal edge position, arch form, horizontal plane, overbite, overjet, and shade of teeth, everything that we would do for a set of dentures. Because essentially, you will find in doing this that there is more denture philosophy or techniques involved in this than crown and bridge. And lastly, we have what we call an aesthetic and functional checklist that needs filled out in full. If you take this checklist and go from top to bottom and address each and every point on it, we will have what we need. It will kind of force you into looking at all these issues that we're talking about. And I'm going to give you some tools that will allow you to do that pretty accurately. This is just a copy of it. It's on our website. You can download it and print it out. So, bites, vertical dimension, and aesthetics. I asked this question not to be critical, and in yellow I have a sentence that says, has digital dentistry caused dentists to omit critical steps? And I find that sometimes, based on what we receive, that it does. I laughingly put a magic bite button in place because obviously we're never going to be able to get one of those, but I'm going to show you why I have that on there, and it's because of what we're asked to do with upper and lower full arch restorations. So the confirmed bite in aesthetics, confirmed bite to us, and something that we feel good about continuing with are cases with positive centric stops that can be handheld together, or bites that the doctor has verified with wax TRYINs, printed TRYINs, or orthotics to confirm vertical dimension and centric. Aesthetic information, photos, and written information regarding tooth position also gives us confirmation of what you want. We get a lot of cases in a day of this. I mean, it's amazing how many people do this. But if I had to say, out of 10 cases that come in, how many we have to stop the process on and call doctors and show them different things that we're concerned about. It's about 70% that don't make it through our triage process. And that's high. That costs time, basically, is what it comes down to. It's not that we don't get the information and cooperation from our customers, but quite often a surgery date has already been set, and we then start to fight the clock to get everything we need to proceed. And that's something we really try to avoid. So I put this slide in here in the form of a question. Do these cases meet the criteria of a confirmed bite? And these are cases we have worked on, each and every one of them. And we don't know how these bites were taken. We have no idea if when you did this in your office, if you're happy with the bite, unless you were to write in your instruction, this bite is good, it's been checked, continue. But all of these don't have the proper amount of centric stops. And when we see this, we have to stop and at least make you aware of it, because the last thing we want to have is a surgery where you get to the final step of putting the prosthesis in, that you have a bite that's just way off. Or we have horizontal planes that aren't correct, midlines that aren't correct, things like that that can be caused by an inaccurate bite. So these kinds of cases here are pretty much what I'm going to focus on as we continue with the presentation. When we get the case, we take your bite that you have scanned and we print it and we connect it with connectors so that it's one solid piece, so that we can't lose the bite registration that you gave us. And we use that as the mounting and the basis from which we decide what, when we analyze this, if we need to talk to you about anything. So photos, we need photos. And what we need are non-retracted, full face smile photos from above the hair to below the chin. If we have photos of only a patient's mouth, their nose and their mouth and their chin, we can't put these pictures into software, because when we do this, there's an alignment process that requires us to have the eyes and also a smile big enough that we can choose points on the teeth that we can correlate and allow the pictures of the patient to be in our software, so that when we put teeth in the picture, everything is accurate. So we need the non-retracted of the full face smiles, and I'm going to show you the ones we need. And we need retracted pictures of the patient's bite from the facial and both right and left sides. So we need one in repose. We will tell from this picture if your patient shows incisal edge or not, or how much or how little, make decisions on length of teeth. We need a natural smile to see, how the teeth align with the lower lip and how the patient will look just in normal situations. And we need an exaggerated smile. This might be one of the most important ones, because as you see, when this patient smiles, they have a gummy smile, maxillary excess tissue display. And this is a red flag, a very big red flag about planning. We have to make sure that we plan this for bone reduction to the point where the transition line between the tissue, the gums, and the prosthesis doesn't show. We have actually an algebraic formula that we use for this now that's very accurate, and I'll explain that in detail when we get to that part of the presentation. This is one that, if we have it, we use it. If we don't have it, it's okay. It's nice to use as a confirmation. We use more than one vertical dimension analyzer. Here we want to have confirmation from a few different sources, so that we feel like we're going to be right with our assumption before we present you with questions about it. But this helps us determine a Frankfurt horizontal mandibular plane angle. And studies, the norm for people is between 20 and 30 degrees. Anything below 20, studies have shown becomes a destructive occlusion, which can break normal teeth down and cause some implant issues. So if we have this information, we can determine and say that, well, maybe we need to over-engineer this case for this patient. Their bites collapse, they grind and they brux, and it needs opened up to the point where this certain situation doesn't exist. So again, that's just another way we confirm what we're looking at. And the bite pictures we use just to confirm any digital bites that you send us, and even analog bites, irregular model bites, so that we can see what the patient's bite is in their mouth and compare it to the scans you send us or the models that we have. So those 7 pictures are the most important ones that we can get to do our analysis on. So our vertical dimension analysis, we suggest that cases without positive centric stops have bite rims made for bite registration, and a tooth TRYIN or a JC TRYIN, which I'll go over soon, to confirm the bite. Vertical dimension opening with openings of 3 millimeters or more. As I mentioned earlier, we suggest an orthotic or a JC TRYIN to confirm the bite and the centric. Physical models, the orthotic and bite can be returned to us to scan into software, or you can take a scan at the bite position that you've confirmed and use that as, scan that and send that to us as the new bite position. Excuse me 1 second. Sorry. So bites confirmed and resolved with the orthotic can be scanned and sent to us as opposed to analog models, but either one works well. So the JC TRYIN is, for lack of a better way to describe it, it's a couple of plastic flippers, either upper or lower or both, that we make to a bite. It's like plastic partials. And this is used to confirm questionable bites. It's used to, as orthotics, to open bites or restore vertical dimension and confirm that that's where we want to work. They can be made, the patient can wear them, you know, for a couple of days if they have to. They're not, it's not made of a material that's meant to last a long time. So, you know, you have to keep that in mind, but we can send these to you. And the most important thing about any of these JC TRYINs or orthotics that we send you, the most important thing I can think of is that when you get these, whether it be an orthotic or a JC TRYIN, they need to be equilibrated accurately into their final vertical and centric position. You need to know that when that patient leaves, that the bite that you develop is the one you want them to use. We get some of these back sometimes where we can see that the patient bit down and hit in the posterior and the rest of the bite is open, and we articulate to that, and our questions are, what is right? Does the doctor want us to equilibrate this until the anterior teeth come together? Is this the right vertical dimension and bite? So equilibration really seals the deal and is one of the most critical steps in this process if you use TRYINs, orthotics, or the JC TRYIN. So this is something that's available anytime you need to have it, and it's been very, very helpful to doctors for bite analysis. And this is what they look like. From left to right, you see the models that they were made on. And on the right side, you'll see the case in the patient's mouth. And this is where you do your equilibrations and make sure the bite is fine-tuned and correct and vertically acceptable. The link that you see at the top is a link to a video that we have on our website that you can access and have a little video on the JC TRYIN. Alan Banks explains it very well and how it's used. You will have access to this webinar so that you can't get this written down in the time I'm showing this slide. You'll always be able to access it. So we have X amount of tools here that we can use to analyze VDO. And these are the same things you can use chairside. And actually, they were meant to be used chairside. So they've been very valuable to us and very accurate, as a matter of fact. So we have Shimbashi, we have fold-to-fold measurements, facial rule of thirds, phonetic evaluations, which doesn't necessarily help us in our workups. It helps you in fine-tuning this patient's occlusion and bite and tooth position as they're wearing their surgical appliance during the healing phase. And also the Frankfurt horizontal mandibular plane angle. So the Shimbashi, which is the one we use the most, is something that I learned when I studied neuromuscular dentistry at LBI. It's a measurement that you take, and you take it from the CEJ of one of the upper centrals to the CEJ of the opposing lower central. And the average measurement that most people fall into are 17 to 21 millimeters. And mostly it's about 17 to 18 is what we see on bites that are in the good range. We have had bites that are 9 millimeters. In other words, the upper anterior teeth completely cover the lower anterior teeth with a collapsed bite. So this is, when we see that, that's a red flag that goes up and says, maybe we need to ask the doctor to look at vertical dimension, in which case we will come up with a suggested opening based on plane of occlusion, based on guidances that we see at that opening, and we will take pictures of before when the case is mounted in the occlusion that was sent to us, and we will take pictures of the proposed opening that we suggest, or so that you can approve it, disapprove it, tell us that maybe that's too much vertical, and give us guidance, or just say leave it like it is. I will say one thing though, in doing single arch cases in a deep class 2 bite, it's very difficult to achieve a plane of occlusion that is going to be relatively stressless. Okay, we're going to have a deep overbite. Protrusive guidance is going to be severe. The looks of it isn't what the patient might be expecting when they get a new appliance like that. So quite often with a deep class 2 bites, the opening it might only be a few millimeters, but with those kind of bites also, we notice we have the ability to raise teeth so that the incisal edges have close to normal overbite overjet without affecting vertical dimension a lot. So that's a lot of that is based on what we see with this Shimbashi measurement as to what we can do with our suggestions. And here is the measurement itself. If you look on the right picture, that's normal, 18.5. If you look at the middle picture, at 16 millimeters, that's borderline. The measurement is a starting point, and we base decisions off of the patient's bite, the opening based on occlusion, tooth display, overbite overjet. And the picture on the left shows a very, very deep class 2 overbite, which, where the anteriors are still intact. The upper anteriors, you don't even see any of the lowers. So we stop the case and let you know. We don't make any decisions on ourselves about that. We just want to make sure that you have the best chance of doing what you think is the best for your patient. So this is a confirmation slide that I have. It shows that the Shimbashi is 18.5, which falls into the normal range. And the fold-to-fold measurement that I mentioned is where we have enough of the mucobuccal fold on both arches to measure in the lateral area from the depth of the mucobuccal fold on the lower to the same position on the upper. And the normal range is 35 to 38. So the Shimbashi is normal, as you see on the left, and the fold-to-fold measurement falls into the normal range. So we know that that's probably good, and I'm sure that you might agree with that. And when we see the patient pictures of cases like this, they look fine. Aesthetically, they might need some tweaks, but nothing with VDO. So if we use this measurement, the patient has to take their picture with their teeth in occlusion and their ear exposed and their lips together for us to make this measurement. So a low mandibular plane angle, the yellow text is the most important part of the text, but what it really says is that a high Frankfurt mandibular angle shows decreased biting force, whereas a low angle has increased biting force. The low angle patients require more rigid prosthesis, usually because of this. The increased biting force in these low angle patients cause more stress to the residual ridge. So that is the benefit of knowing what that angle is. And I don't know that, we hardly ever get any information on that, not to say that you don't do it when you base your vertical dimension positions and give us that information, but something to really keep in your mind as far as what these low angles can cause as far as stress is concerned. And the high angles, if you make a restoration out of zirconia, for instance, and there's not a lot of freeway space, those are the cases that might exhibit some clicking when the patient gets those in their mouth, like the old porcelain teeth that the dentures used to have. So that's something to consider if you're, if you want to use zirconia on cases. Prognathic bite, no centric stops, as you can see. What we don't know is when the patient bites down into that position and we get a bite like that, if, even since there's nothing holding the posterior into position, did the joints move during the bite and during the bite registration phase? So this is one where we would suggest a JC TRYIN here, maybe an orthotic. The upper teeth are behind the lower teeth, and to get any kind of aesthetics without flaring the teeth out over the lowers would require a bite opening on this too. So we look for these kinds of bites as with a red flag. So more red flags. The patient on the left, the lower anteriors are the upper anteriors are behind the lower anteriors. It looks like a collapsed bite. On the right, we have maxillary excess hyperplasia, gummy smile, which needs analyzed a lot differently than our normal cases. These are pictures that we have found. Some of these are from, most of these actually are from cases that we made and were presented with. But when we see pictures, for instance, the upper left, the sunken in cheeks, the picture next to it with the man's face with the frown in the corner of his lips, the lady with the jaw right, the picture next to the far left, you can see the difference in her face with open video versus closed. And pictures where people just don't have any stops, like you see the picture on the right top. The bottom shows, these are actual cases we've worked on where we have had to open or restore vertical dimension for success. The picture on the bottom left, however, can be kind of questionable in as much as there's a lot of attrition and these teeth are end to end. And this could be altered passive eruption with the vertical dimension still being good. So just because a Shimbashi reading shows less than normal doesn't necessarily mean we have to address vertical dimension. So that's just something we keep in mind too. Lack of posterior centric stops. I'm just giving you examples of cases that we really look close at for orthotics or TRYINs. Deep class 2, no centric stops, those kinds of cases. There's another one. Now we did make an orthotic if you look at the picture on the right, okay? One thing I will say on these pictures is this, and the reason I put earlier digital dentistry causes us to omit certain steps is that if this case were going to be a partial denture, for instance, free end saddles, partial denture, no centric stops, the first thing we would do is take impressions and make a bite rim. Then we would have teeth set in place to confirm the bite. And then we would go to finishing. And that's something when we get cases where we have just a few centric stops and the prescription reads that we want to make upper and lower full arch restorations, that kind of scratch our heads and say, maybe we should talk about this more and discuss it with you and see if we need to do any of these analysis of vertical dimension and centric before we start. There's just another example. Here's a result. This lady was collapsed and we gave her that smile. So if you, how do you send us information once the video and centric are confirmed with an orthotic? You can send us the case just like this, as I mentioned earlier in the presentation. Send us the models, the bite, and the orthotic back, and we will put that in the computer and scan it, and that's the bite we'll make your final PMMA surgical appliance for. Or we can use a digital model technique where the patient has the orthotic in their mouth with their teeth together, and you scan them in that position, And that's what we will put into the software to do your case with. Here's the gummy smile, and I will go into our formula that we use for that and how we determine what to do. This patient, obviously, you can see she has a gummy smile, and I want you to notice right now the distance between her upper and lower lip when she smiles. So what we do is measure at the centrals. In an exaggerated smile, we measure from the high lip line to the incisal edge of the central, and we record that measurement. And the picture that you see on the right is why I say that, because if we don't take the pains to make these measurements and analysis, we could end up with something that looks like that picture, where you can see the transition line between the appliance and the patient's gums, and also see abutment head sticking out. Okay. So our formula, we use algebra to do this now. We used to ask doctors to send us pictures, but we can make these measurements on a photograph algebraically and come up with the same number that we would find from a picture. But the incisal edge to high lip line measurement, whatever that is, we add 4 millimeters to that, and that's where we put the top of the implant. That also tells us how long the implant can be. That also tells us if we have enough bone even to do that, in which case, if we don't, we might have to go to a crown and bridge restoration. After we get the implant in that position, we then make sure we have 13 to 15 millimeters of restorative space. And in these cases, I like 15 because of the nature of the kind of case it is in the first place. So if the incisal edge to high lip line allows 15 millimeters of space, no adjustment is needed. If we need more space, then we have to go to a shorter implant or change prosthetic options. So that's what we do. You see all these numbers here on the screen. The 15.14 is our restorative space. You see the orange outline of the appliance. We allow, the reason we add 4 millimeters to our formula is for soft tissue. We don't, in these kind of cases, usually soft tissue is 2 to 3 millimeters. We built in an extra millimeter. And we will discuss that with you as we're planning. If you don't want to use 4, we can use 3, so you don't have as much bone reduction. That would be your call. So we have a way to fix that, and that's how we do it. This is a case we did it on. We ended up having to do crown and bridge. And if you notice her smile, the space between her lips with her original smile and the space between her lips with her new teeth, with the new appliance, is a lot less. And we did adjust vertical a little bit, not a lot. It was just she had an overbite that allowed us to move the teeth up more without having to do anything with vertical dimension. And we did a crown and bridge case. So this is after her surgery and after she had her final appliance for a couple of months. And this is the girl you saw before. That's the result that she had with her gummy smile. And notice again that the amount of space difference between her gummy smile and her final restoration with the guided smile case. So it's a major difference in their lives. So once the bite and the vertical dimension are confirmed using the protocols described, the case now is ready for the guided smile process to begin. So what I'm saying is, this analysis should be done before you send us anything. If you do, I mean, it's upfront work, yes, and it might take some time, but it takes a lot of stress off of the case as far as timing is concerned, because we know that once we plan this case, we can continue with it smoothly, have your patient in, get case to you on time, and have as close to good occlusion as we can get. So I ask you to consider looking at all these things, and if you're not doing it already, incorporate it into your workup on these cases when your patients come in, and see if it doesn't help this process go along. I'm always available for questions, if you call the lab, my extension here is 303. You'll find a number, almost done, and you can get a hold of me. So that brings us to the end. I would like to thank you today for your participation. And as this says, stay safe out there. This crisis is going to end, and we just want all of you to be there and healthy when it's time to go back to work and get all stressed up again. So is that okay? Now we can do some chat. At this point, we'll take questions. We can do chat, and I will answer anything at all that you want us to talk about. So, okay, the question is, can TRYIN be used to mill custom abutments for single or multiple implant crowns? We could do it possibly for temporary abutments, but we would not want to use that for final abutments. It doesn't meet the thickness requirements for permanent restorations in that application. Second question, if nanoceramic is unbreakable, why use anything else like zirconia? Yeah, well, when I mentioned that it's strong, I did not say unbreakable. When we, in our early attempts to do these, when we first started using this, we did have some fractures, and it was all because of design. We became more educated with it. We changed our designs. And at this point, since we have done that, we have not had fractures. So anything can break. But design is the secret to the TRYIN. And I think we figured that out now, and I wouldn't say that I would not. I'd recommend it to anybody that wants to use it. Okay. Okay, Dr. Schall. I believe zirconia is better aesthetics than nanoceramic. Usually, they recommend maxillary zirconia and mandibular nanoceramic. That is a good observation, and that is in fact true. The hard surface against the softer surface is good. We do make zirconia prosthetics against each other. And as I said earlier in my presentation, I think that freeway space is something that you have to analyze very well, because if there's not a lot of freeway space, these patients will get clicking, okay? Some patients don't like the feel of that hard glassy surface against each other. The one thing I will caution you on is that because they're differing materials, it's harder to make the shades match exactly. So that's why, you know, we want to have the zirconia on the upper and the nano on the lower. Yeah, and you know, you should probably let your patient know that we're going to get the shade as close as possible, and usually it's very close, and sometimes it's right on. But again, because they're different materials, and depending on the shade puck we use, they can be a little different. Okay. Okay. A customer person wants to know the difference between a JC TRYIN and an orthotic. Is the JC TRYIN tissue-borne, orthotic tooth-borne? Actually, we actually had a discussion about what to call these. The JC TRYIN can be used as an orthotic because we can open the bite with it. The patient can wear it for a period of time to see if everything is okay and comfortable for them. If you want to use it as an orthotic, say, please make JC orthotic. And if we need to put some wire clasps on it so it stays in place, you can request that too. But they're both one and the same. Oh, okay. There was a question here as to where on our website is the document regarding the in-depth patient evaluation. We see all the questions and the doctor's names here. We will email you that, or you can call me here at the lab, Joe Ambrose at the lab number extension 303, and I can go over all of that with you. Question, nanoceramic, while it flexes, can be broken past the shear value. It is prone to long-term wear, or is it prone to long-term wear? Anything that nanoceramics can wear, yes. They are stronger than denture teeth, at least the Ultra is. So the wear factor is something that you know, it's going to take a while. I can't guarantee you time limits on that. But one thing about the nano ceramic that's nice and the way we do it is that if you reach a point during the wearing of this appliance and the patient wears the teeth down, we can retread this. We can get the frame back with the model. We can strip down the Ultra Nano or the Crystal Ultra teeth from it, and we can restore it with the exact teeth vertical dimension that the patient started with when we restored them, initially, because we save all of these files. They never get deleted out, and we'll just go back and reprint or remill what we did the first time around. So that can be taken care of. Well, okay, fees. That's a question that comes up just about every time we talk about this. It depends on your area. If you work with a surgeon, then I suggest that you and the surgeon, before you see the patient at all, as soon as you know that you have a patient that's interested in this, make sure you know your surgeon's fees and make sure the surgeon knows your fees, because that can be a sticking point if the patient goes into it thinking they're only paying for, if they're paying for surgery, that includes everything. So if you are a general practitioner, I can tell you what some of the average fees are, at least around here. I think an average arch is $25,000, maybe a few more, a few less, depending on practitioner. Yeah, and with Chrome, it's probably going to go up a couple of $1,000s on that. So the good news is that we don't see any problem getting these cases. We are inundated with them, and there's plenty of people that want to do it. I tell you, I go back to my first slide that I showed, one of the first slides where it says this is life-changing. People are desperate to look good and feel good, and they pay for it. So you'll get some no's, you'll get an awful lot of yeses too. Well, next question, what would be the restoration of choice for a case of 30mm video versus 18mm video on 30mm versus 18 video upper and lower? Well, 18 video on upper and lower means that we only have 9mm of an arch to work with. So that would be a crown and bridge restoration. 30mm of video means that we could do probably just about any kind of restoration you wanted. We could do a fixed removable hybrid like we're talking about now. We could do removable overdentures with the bar. We could do FP1s. However, FP1s with that opening might cause teeth to be really long, and you'd have to have pink porcelain on it. So it depends. The closer the minimum vertical dimension that we like to work with upper and lower, and that depends on where you're measuring from too. If you're measuring from the tops of the implants to a surface on the restoration, we like to have 13 to 15. If you're measuring from the arch, from one arch to the other at the alveolar ridge, we like to have 13mm of restorative space per arch. So that's 26, okay, for these kinds of restorations. And that's why I mentioned earlier that if you don't have the space, don't do fixed hybrid cases, because they turn into really nightmares. So the 18, I would say, is going to be crown and bridge type restorations, FP1. Okay, next. What are your thoughts on the cross-linked high-flex resin polymers like Pecton and nanoceramic for definitive long-term prosthesis? From a lab perspective, can these materials hold up past 7 years? What is the data saying? No, I think that they can work. Yes, designed properly. We don't do Pecton, right? No, we don't do Pecton here. But from a lab perspective, you ask if the materials can hold up 7 years. I would say that I don't know that any laboratory can guarantee anything will last for 7 years. Now, having said that, you know, we don't have a big issue with that, and I don't think most labs either. But to guarantee something like that, it should hold up for 7 years, but I don't know. I don't know what the data says about Pecton because we don't use it. But the nanoceramics, under normal use, what is our guarantee on those?
6 years.
We have a warranty of 6 years on our hybrid appliances, on our nanoceramic appliances. So if anything happens with 6 years, we're going to cover it. As with any dental appliance, though, depending on the patient and their situation, things could happen. We don't have a lot of issues with breakdowns and issues like that. We have every once in a while, we have it like every lab does, but it's not a major problem at all. Okay, well, thank you very much. I am happy to present this. I don't know if where you are in the world today, but I wish you all well. Thank you for attending today. And tomorrow at the same time, there is going to be another presentation given by Dr. Adam Folick on this topic from the dentist side. So I appreciate it. I hope we get back to work soon, and everybody take care. Thank you.